Okay, let's go ahead and get started. My name is Allison Ward, and I'll be facilitating today's webinar sponsored by the National Center for Hearing Assessment and Management. Today's webinar is Congenital Cytomegalovirus 101 from Prevention to Treatment, and will be presented by Dr. Michael Cannon, epidemiologist at the Centers for Disease Control and Prevention. Before we get started, I'd like to make a few announcements. As William indicated a few minutes ago, the webinar is being recorded, and the recording will be available on infanthearing.org and cmv.usu.edu. An email will be sent to all registrants with a link to the recording. Also, if you need IT support during the webinar today, we have limited assistance at 435-797-3490. This number is also located in the left corner of the presentation note field. And if you need a certificate of attendance for today's webinar, please email me at allison.ward@usu.edu. My email is also indicated in the text box on the left-hand side of your screen. We will be doing questions at the end of the webinar today. We will be doing it through the text field. A Q&A note text box will be opened up when that time comes, and we will indicate that. And we are doing this webinar as part of our preparation for the CMV Public Health and Policy Conference. I will be speaking briefly about the conference at the end of Dr. Cannon's presentation. If you have questions about the conference, please take note again of my email in the text box on the left. Without further ado, I will turn the time over to Dr. Cannon.
Hello, everyone. Thank you very much for the opportunity to do this presentation, and to NCHAM for organizing this and inviting me. Like Allison said, I'm going to try and give a Congenital CMV 101, the basics. And I would say that although I'm going to address kind of a wide range of topics, I am going to focus more on the issues related to newborn screening, but I'm going to try and provide some resources at the end for some of the other issues related to congenital CMV that can help you, point you in the next direction if you want to learn more. So to begin with, there are two basic ideas. The first is that children who are born with congenital CMV, they can have transient outcomes that can be, sometimes they're asymptomatic, but when they do have symptoms, they can be non-specific things like enlarged spleen or enlarged liver, jaundice, and so on. The bigger concern is when there are permanent outcomes that can sometimes be present at birth and sometimes develop or are detected later on. And the ones of biggest concern and most highest frequency, and I'll say more about this later, are hearing loss, intellectual disability, and vision loss. And children who have symptoms, they can have multiple symptoms or just one, or multiple permanent outcomes or just one, and the severity can range widely as well. In the United States, it's estimated that about 30,000 children are born with congenital CMV infection, and about 10% or a little bit more are symptomatic at birth, so they appear sick at birth. Some of these children die, although that's fairly infrequent, and overall about 1 in 6 will either have or will develop the permanent outcomes such as hearing loss or intellectual disability. And just to put this into perspective, a lot of people are unaware of this, but children who have long-term permanent problems because of congenital CMV, they're about the same number as have some of these other better-known conditions, such as fetal alcohol syndrome or Down syndrome. So one thing we try and point out is not that congenital CMV is more important than these diseases, but that it's in the same ballpark and it needs attention and needs to be addressed. And it's also been estimated in an Institute of Medicine report that more than $1 billion in direct medical care each year are due to congenital CMV. However, most people aren't aware of congenital CMV, and the reasons make sense. So when adults get infected, they typically are unaware of their infection, and they may have some non-specific symptoms like the flu, but often don't get tested, or they could have been infected when they were young. So mothers don't know that they're infected, and many of the babies who get infected during pregnancy are asymptomatic at birth. So, there's no reason to suspect that they have this infection. And even babies who have symptoms, as I alluded to previously, the symptoms can be non-specific. And another challenge is that in most instances, you need to test for congenital CMV within a few weeks of the baby being born. And so often you can't go back and definitively diagnose congenital CMV. Although I'll say more about that later, because there are cases where if there is a dried blood spot available from newborn screening, that sometimes that can be used to get a definitive diagnosis. But because of these reasons, often if a child has some developmental problems or other related illness, you really can't be sure that it was caused by congenital CMV. Now, getting at the biology, what happens is CMV, Cytomegalovirus, is a member of the herpes virus family. So like these other herpes viruses, like varicella zoster virus, which causes chickenpox, and shingles, or the herpes simplex viruses that can cause cold sores, you have this primary infection that happens, but then the immune system controls the virus, and mostly you don't have symptoms. But later on, somebody who had chickenpox could develop shingles, or somebody with a cold sore, it will reactivate. And so CMV is like these other herpes viruses, that you can have a reactivation, but you can also have a reinfection with a different strain. And these latter two items here, if you can see the green arrow, they are sometimes called recurrent infection or secondary infection, or often they'll be called non-primary infection, to distinguish them from the initial infection over here. Now, to help you understand the rest of the slides, if you don't have a laboratory background, I wanted to provide you some of the vocabulary that can make some of the other results plainer. So if you want to measure whether someone has ever been infected with CMV, that is sometimes called seropositivity, or you'll hear the term seroprevalence. And what it detects is antibodies. So it doesn't detect, you're not detecting the virus itself, but you're detecting the immune response to the virus. And there are different ways that this can be tested. One of the most common that you might see, the test format's called an ELISA. If you want to know whether someone is at risk for transmission, or sometimes that's called shedding or excreting the virus, and to do that you need to detect virus or viral DNA. And the way that is done is using PCR or culture. So these things can help you, if you want to know, have you ever had it, you would use an antibody test, you would test for seropositivity. If you want to know if someone's at risk of giving the virus to someone else, or if you want to diagnose a baby, you would use this second kind of test for the virus itself. Okay, so now that we are familiar with the terms, I wanted to talk about seroprevalence. So that means the prevalence of people who have ever been infected. And of course that goes up over time because it's cumulative. And what you can see from this slide is on the x-axis we have age, going from children up to people in their 40s, and on the other axis we have the prevalence of CMV infection, whether someone has ever been infected. And you can see in young children, now these are different racial ethnic categories, and here we have Mexican American, non-Hispanic blacks, and non-Hispanic whites. And you can see that those are different, that seroprevalence is higher in Mexican Americans, and then next in non-Hispanic blacks, and lowest in non-Hispanic whites. Over time it goes up, and you also can see in some of these risk groups, actually in all of them, that it starts to get higher for females. If you compare non-Hispanic black females to non-Hispanic black males, you see some differences there, and the same thing in the other groups. So that kind of gives you an idea of who's infected, when they become infected, and how that changes over time. Now, if you want to know, well, what if you looked at a group of people who've never been infected? So in the previous slide was just looking at cumulative measure of whether someone's ever been infected. But if you wanted to look and take a group that's never been infected and follow them up over time and see how frequent new infections are, that's what's called seroconversion, or sometimes seroincidence. And what you can see from this figure is, on the y-axis, the number of CMV infections per 100 people who are susceptible, who've never been infected, per year. And so, this would be 1 per 100 per year, or 1% per year. And then it's broken down by race, ethnicity, by socioeconomic status, and region. And the takeaways from this are that, again, for new infections, you're seeing higher rates in non-Hispanic blacks and Mexican Americans, closer to 5 or 6% per year compared to a 1.5% for non-Hispanic whites. And you also see a difference by SES, that lower SES has higher rates of new infection compared to middle or higher SES. And this starts to give some clues about whether, how do people become infected. Here's another clue. So if you look at children who, so we did a study of children, and we looked to see if their older sibling had CMV and if their mother had CMV. And what you can see, and I think I actually misstated it in the bullet, but the children who have an infected sibling have a much higher prevalence of CMV infection themselves. So they're 30 to 50 percentage points higher prevalence if they have an infected sibling compared to other children who don't have infected older siblings. And a very similar pattern with their mothers. If their mother is positive for CMV, they're much more likely to have it themselves than if their mother is negative for CMV. So this provides another clue that transmission between family members is a distinct possibility. And I'll show you some more data that really shows that it's an important mode of transmission. So what this table shows seroconversion. So it's what happens if you follow people who've never been infected and you look and see how many infections do they get over time. So it gives you a rate. And this is a summary. It's from a literature review of dozens of studies. And it combined the groups in the studies according to their different risks. So if you look at just pregnant women, you can see that about 2.2% per year become infected. So that's 2 per 100 every year on average. And you see similar rates if you look at studies of parents who have children who aren't shedding CMV, so they don't have CMV in their body fluids. If you look at healthcare workers, including those who care for children in the NICU, so who definitely would have exposure to CMV, the rates aren't much different. However, if you move to daycare providers, the rates of infection go up about threefold. And also, if you look at women who are attending sexually transmitted disease clinics, you see higher rates of seroconversion. And then you see your highest rates among children who have a child who is shedding CMV. So it really indicates that children with CMV infection are at high, are an important source of infection. But exposure, if you have exposure to sexual risk factors, that's also important. And it's worth pointing out that even though these rates are fairly high, that only about 1 in 4 parents catches CMV from their child who is shedding. And you can kind of put that in perspective if you think about if you had a child who had a cold that lasted all year, and you only had a 1 in 4 chance of getting infected, you know, that seems unlikely for a cold. But for CMV, that's about what we see. And once again, if we compare, these are mathematical models. And if you compare how contagious, you can think about it as how contagious it is, comparing CMV to some of these other infections. And the parameter that gets used is called this force of infection. And it's basically, you can think about if you had 100 uninfected people, about how many would get infected over the course of a year. And again, these aren't strictly comparable because of age differences, but you get the general idea that measles, mumps, and rubella, much more infectious. Varicella is kind of in between, and then the studies of CMV fall in the middle. And then if you look at herpes simplex virus type 2, which is exclusively sexually transmitted, you get a lower rate, which, so these things might imply that CMV isn't getting transmitted through the air the way measles, mumps, and rubella can, but it gets transmitted perhaps in additional ways besides sexual transmission when you compare it to herpes simplex virus type 2. And also if you compare it to hepatitis A, which I believe is primarily foodborne, and hepatitis B, which is primarily blood transmission, you can see that CMV is more easily transmitted than these infections. Now we're going to moving from seroprevalence or seropositivity to shedding or excretion. So these are data that help you understand who is at risk of transmitting the virus to other people because they shed it in their bodily fluids. And I hope it's clear enough here, but these dots come from individual studies. So each dot is an individual study or a group within a study. So this figure represents a literature review of dozens of studies. And what you can see, I'll just point out a couple things, is so on the y-axis we have the percent who are shedding, and then we have the different risk groups on the x-axis. And I just want to point out, if you go to healthy children who are in daycare, you see this higher, a median of about 23% of them are shedding CMV. So it's very common in healthy children. And so it's not just children with congenital CMV who go on to shed when they get older, it's healthy children, so very common. If you look at children who are not in daycare centers, you still see a lot of shedding, about 12% median, but clearly exposure to other children in daycare settings seems to be a risk factor. And let me just point out the adults here. Adults who don't seem to have particular risk factors, they also can shed, but their median is lower, whereas adults with specific risk factors such as having a child who's infected or attending an STD clinic, they have higher rates of shedding. Okay, now same sort of idea, but let's look at it by age among children. And each of these lines, now some of them are a little hard to pick out, but if you follow the lines, they show the prevalence of shedding by age, and so it's mostly children under 5. And in this literature review, we've broken out, a lot of the studies have been done at Alabama, University of Alabama, Birmingham, so we just separated those out. But the basic idea, if you look at panel B and panel C, is that you can see, let me see if I can follow one of these, that shedding prevalence is kind of low in the very youngest children, and then it tends to go up, in the 1 to 2 range, and then it seems to drop back down in the older children. And again, these trends aren't perfect, but they give you a basic idea that indicate that if you're thinking about how CMV is getting transmitted, it's more likely that exposure to a younger child is going to put you at risk as compared to exposure to an older child. Now this slide, I just want you to remember, is just the prevalence of children who are shedding, so 50% or 20%, whereas this next slide is going to show you the viral load. So this says if you have somebody who is infected, what quantity of virus is in their fluids. And these are unpublished data, so these data aren't as robust because they only come from one study, and are more tentative, but they give you a basic idea. And the place I want to start is, let's start over on the right. And basically what this says is this y-axis is the viral load. And this shows that each dot is a measurement from a child. And it suggests that you, on average, have higher viral loads in saliva than you have in urine. If you move over here, I'll have you focus on this panel A. What this shows is that as you get older, your viral load, if you're a child who is shedding, tends to kind of go down. So the children who are youngest seem to shed at the highest viral loads. So that's point number 2. And point number 3, and there's fewer data on this, but just so you can compare, if you look at viral loads in young children, in the saliva of young children, and compare them to their mothers, now there's just a few data points, but we did see a significant difference. And this implies that it's probably easier to catch CMV from a young child than an adult, and it's probably easier to catch CMV if you're exposed to saliva than if you're exposed to urine. So to summarize, and this schematic kind of puts things in the context of a pregnant woman, is that you really need direct contact with bodily fluids. You're not going to get CMV by sharing an elevator or shaking hands with someone for the most part. There doesn't seem to be evidence of that. Saliva and urine appear to be important fluids for transmission, and as I said, in most cases, the highest viral loads are in saliva, and young children appear to be a major source of infection. However, CMV appears to be transmissible through intimate adult contact, such as sex or kissing. Let's see. Okay, so this slide here is just to make you panic, but I'm going to walk you through it. And I wanted to show it to you because it gives you kind of the big picture of the epidemiology of congenital CMV infection. And I'm going to show it to you twice. The first time, just to give you a sense of who gets infected, and the second time, and who gets disease. And the second time, I'm going to talk about intervention, what interventions appear to have some potential benefit. So these numbers are from the U.S. Census, I forget what year, just a few years ago, about 4 million live births. And you can see that the best estimates, again, these numbers are, they're approximate. They're not especially precise, but they're the closest as we can get to with all the data in the literature so far. So in the U.S., maybe about a little less than 1% of children are born with congenital CMV infection. So maybe 25,000, 30,000 children. And we'll kind of ignore this group over here, the uninfected children. But if we look at these 25,000 children, a little more than 10% of them will seem to be sick when they're born. So that's this group here. Maybe a little over 3,000 will be sick when they're born. However, let me point to what I really want to emphasize here. I'm going to skip these groups here and talk about them later. Is that as far as hearing loss goes, you'll see that about 815 and plus 670 and a bunch of these other children will have hearing loss. So some of them this will happen when they're born, and some of them will be delayed. And if you go over here to the children who are asymptomatic at birth, most of them won't have hearing loss, but if you add up these groups here, about maybe 10 to 15% will develop hearing, about 5% will have hearing loss at birth, and then maybe another 5 or 6% will develop hearing loss later on. So that's kind of the basic epidemiology, and it suggests where you might intervene, and it also suggests some of the issues surrounding intervention, and I'll talk about them more explicitly when I show this slide again. Let me point out that this hearing loss, the way it's been measured in the literature for CMV, some of it is less severe. Some of it's unilateral, so about 70% is unilateral or mild bilateral. So it's not all severe or profound. Okay, so this is the basic epidemiology, and I hope it's not too complex, but you can refer back to it if you have questions, and I'm going to show it to you again and talk through more of the issues on this slide. Just to give you an idea, kind of the classic study from Alabama Birmingham that really lets us understand when hearing loss occurs, you can see, so what they did, and these are hundreds of children with congenital CMV, or maybe more than that, followed over time, and you can see the cumulative hearing loss. There's a big chunk of that happens right at birth. So you can't really see. But of the symptomatic kids, about 15% have hearing loss right at birth. And then you can see a percentage develop it later on. And also, if you go down to these asymptomatic children, there's a much smaller, it's kind of blocked, but about 5% have hearing loss at birth, and then another 5 to 6% will develop it over time. So again, these, if you go over to the right, these are the children that aren't getting detected with the universal newborn hearing screening. Now this is kind of a different way of thinking about it, which shows that if you looked at all the children who have hearing loss, how much of that can be attributed to CMV, congenital CMV. And again, these estimates are a little imprecise, but these are kind of the best estimates, that about 1 in 5 of children with hearing loss have it because of congenital CMV. So the takeaway points, and this one might have been obscured a little bit, but in a previous slide, the slide with all the boxes, the flow charts, non-primary, well, maybe there's another slide, come to think of it, but anyway, non-primary maternal infection is an important source of congenital infection. So it's not just the primary infection that you have to be concerned about during pregnancy. As I said before, about 0.5% or 1% of newborns are infected, and of those, you have some range of disability occurring at birth or developing in about perhaps 15 to 20% of these children. And congenital CMV is a major attributing cause of childhood hearing loss. So I'm going to shift gears a little bit and talk about what can you do about this? What can be done? And some of these I'm not going to say quite as much about, but I'll try and give you a preview, and then, as I said, I'll give you some resources later on. So vaccination, of course, would be the ideal intervention. There's not currently a licensed vaccine. A number of vaccines are in clinical trials, but it's a really tough nut to crack, and it doesn't look like we're going to have a licensed vaccine in the near horizon. But anyway, that's a really important area of research. Prenatal screening is something that gets debated and is not typically done in the United States. It is done in several European countries more routinely, but I'm not going to really go into details there. I do want to say a little bit more about behavioral intervention, and that's kind of the thing that I've been researching more lately. And if you go to the CMV conference in Salt Lake, you'll get an earful of that from me. So I'll say more about that later. But the basic idea is that if you are exposed to young children during your pregnancy, there are some specific steps you could take to reduce those exposures. And we typically tell women that the 3 things to particularly pay attention to are when you're kissing a young child, to avoid saliva by kissing them on the forehead or cheek. Number 2 is to avoid sharing food and drink and utensils with your young child. So, or a pacifier, cleaning a pacifier in your mouth. So basically, if it's just been in your child's mouth, you don't want to put it in your mouth. So that's the second behavior. And the third behavior is if you get urine or saliva on your hands, or you think you might have, to wash them, or if you don't have soap and water, to use a hand sanitizer. So those are kind of the big 3 things. If you're around young children a lot, it's not easy to get CMV, so there's no need to panic, but there's some common sense things you can do to keep those fluids from getting in your eyes, nose, or mouth. We also talk about if you have sexual partners, we encourage people to reduce their exposures by not having new sex partners or by limiting new sex partners during pregnancy. So those are kind of the behavioral ideas, and studies have been done and are ongoing to see, what approaches to those messages are more effective in changing behavior and so on. So it's an exciting area of research. Moving on, there are some potential treatments to prevent fetal infection or fetal disease, and I'll kind of sum them up. One of them is to use hyperimmune globulins, especially those that are specific to CMV, and the data on those are ambiguous. It's not clear whether this sort of treatment prevents fetal infection or prevents fetal disease. So it's definitely, it gets done in certain situations, and there may be some benefit, but it's kind of a controversial area in the scientific field. And then the other approach that hasn't been studied as much is to use antiviral treatment, especially an antiviral drug called valacyclovir, which is used to treat cold sores or genital sores for herpes simplex viruses. And so that's under study, but there's no clear evidence that it is effective. So those are kind of things to do during pregnancy. I'm going to focus now more on the newborn screening for CMV and early detection and intervention. But I just want to point out that really none of these interventions is routine in the U.S. So even though there's some approaches and some research being done, or some pilot work being done, particularly in Utah related to newborn CMV screening, in general, these interventions are not done. So that might be unfortunate, but also it's an opportunity. But it also shows that the science is really in a spot where we're trying to figure out what really would be beneficial and what isn't beneficial, and also assessing not only benefits but risks as well. So as far as, and I would say here, universal newborn CMV screening. So there's some reason to believe, and this is what's being done in Utah currently, is that children who fail their newborn hearing screening are being tested for CMV as well. So that's really what's called a targeted newborn screening rather than universal. And it's more likely that the benefits are higher and the risks are lower for this targeted screening currently, and that the evidence relating to universal screening requires more work to assemble and assess. But if you think about the typical ways that screening programs are assessed, in particular newborn screening, there's often criteria that get used to determine, is this good public health policy? Now, CMV probably satisfies several of those as far as being an important health problem. It has a recognizable latent or early symptomatic stage, and although we don't know everything about the natural history, we know quite a lot. Now, there are a number of items that may not yet be satisfied. There are very good tests for CMV. So the issue isn't that we don't have good tests. The issue is that we don't necessarily have tests that are really cheap, really easy, or that could be fit into the current newborn dried blood spot programs. So just feasibility and cost and cheapness are issues that are still being addressed for CMV tests. There is some evidence that tests could be acceptable to the population. I'll show you a little bit of data on that. There is perhaps some ideas as to who to treat and how, but that's still debated. And this is probably an issue with all universal screening for different conditions. Are there facilities available for diagnosis and treatment? And if these interventions are effective, are they cost effective? So I'm going to just talk about briefly a few slides about these, and then I'll wrap up. So just to give you an idea of what specimen would you use for newborn screening and what type of and how it might fit in, the three specimens that have been considered are dried blood spots, saliva, and urine. And for all of those, for the most part, the method for detecting them, really the most feasible method would be PCR. And the advantages for dried blood spots, and this is a huge advantage, is that there's already a very well-developed program in every state for dried blood spot screening, and the state health departments administer it, and so it really has this important infrastructure that makes it possible and that makes follow-up much easier. As those of you who work on newborn hearing screening know, the many difficulties of follow-up because of the nature of that screening program. The big disadvantage for dried blood spots is biological, that CMV viral load is just lower in blood than in saliva and urine. And it's hard to get as much blood out of a blood spot, and there's usually less available because it's used for other things. So that's a real challenge, and some children who have congenital CMV are going to be missed if you're using dried blood spots. The question is, are the ones that are missed unlikely to develop disease anyway? That's possibly true, or at least true for some of them, but that's the big disadvantage for dried blood spots. For saliva and urine, the advantages and disadvantages are similar. You get typically very high viral loads in those specimens, typically hundreds or thousands or more times as much virus in those specimens than in blood. And it's easier to get more of the specimen if you do collect it. The big disadvantage is that sort of collection isn't part of an existing newborn screening program. Some ideas about this might be to include saliva collection as part of newborn hearing screening. Another idea that's been proposed is perhaps putting saliva or urine onto filter papers that could be processed in the same system as dried blood spots. So there's different ideas and approaches that could be promising, but they're still in the developmental and research stage for the most part. just to give you an idea about, well, what sort of treatment can be done. There's really two approaches. One is pharmaceutical, and one is non-pharmaceutical. The evidence for pharmaceutical treatment primarily comes from a single study, although there's a second study that his enrollment has been completed, but those data aren't yet published. But the basic idea was that children who were, in general, very sick, who had central nervous system deficits, were randomized for treatment with this IV antiviral drug called ganciclovir. And those who received the treatment were less likely to experience worsening in hearing loss, and they also seemed to have somewhat better developmental outcomes. But they did have significant neutropenia often. In the follow-up study, the data, they used an oral drug, which would be much better as far as side effects and feasibility, and they've also included children who don't necessarily have central nervous system deficits. So there's some evidence that antiviral treatment could help. It has potential for important adverse effects, and it has really only been studied in very severely affected children. Okay, so I'm back to this spaghetti here, and what I wanted to point out is that there is some evidence that if you had early detection and intervention for CMV, that you could help some children who aren't currently being helped. So in other words, if you did universal screening for CMV, there's evidence that suggests that it could be beneficial. Let me just point you to, we're going to start out with these symptomatic children who aren't diagnosed clinically. So there's a big group who are just sick enough that they're going to get diagnosed by their doctor. They're going to get tested. There's a big group who may have jaundice or, an enlarged liver, but don't seem really sick, and maybe they don't get diagnosed. They don't get tested for CMV, and they don't get diagnosed. For these children, some of them will have hearing loss at birth, and those will get detected through universal newborn hearing screening. But then some of them will have delayed hearing loss as well. And the idea is that for these with hearing loss at birth, if you know that it's caused by CMV, you may consider treating them with antiviral drugs. Now, we don't really have evidence of treating older children with antiviral drugs, but there is evidence that if you identified these children early, so if you knew they were CMV positive and so you were following up and doing audiological follow-up, and you could identify their hearing loss early, you would get them into the same sort of early intervention that you would for children who have hearing loss at birth. And so there's some good evidence that you could help these children, the same sort of evidence that you can help children who have hearing loss at birth. And the similar idea is up here for the asymptomatic children. If you know they have CMV, you follow them closely, and if you identify that hearing loss early, then you get them into early intervention. And so that's the idea behind the benefits, the potential benefits for universal newborn CMV screening. So I'm sorry if that's a lot to throw at you, but there's some evidence that both pharmaceutical and non-pharmaceutical intervention could be beneficial if children were screened. I'm almost at the end, so hang in there. We do have some evidence about newborn screening, the acceptability of it. We did a survey and asked people, after we gave them a brief background on CMV, we asked them these different questions. And if you look at the middle three, you can kind of see, we said not only would you want your baby tested, but, would you want your baby tested if the hospital didn't do it routinely, or if you had to pay $20, or even if would you want the testing done even if your child never developed problems. And most people said they somewhat or strongly agreed with these three middle statements. So most people viewed screening favorably. A minority said they thought that the problems are too rare to worry about, or that they worried that the test would lead to unneeded doctor visits and expenses. So there's some ambivalence there, but a general positive view of newborn CMV screening. And just, I think this may be my last slide, but as far as future directions, I mean, it's an exciting area. There's a lot going on. There's a lot that really could be done that would be beneficial. Looking at dried blood spot assays to see if there are formats or ways to do it that would be more sensitive or more effective. Looking at tests that you could do on site for saliva or urine, like a rapid strep test. You know, if you could do a rapid CMV test in the, when the person comes in to do the newborn hearing screening, for instance. Looking at using filter paper for urine or saliva collection. Looking at, what are the effects on parents for screening. What are the best protocols for follow-up for infected children? Looking at pilot studies for how would you do universal screening. And the last one is what's being done in Utah, and I think has been done or may still be done in Minnesota, which is targeted screening. So there are a number of really exciting approaches that are being done or planned that could really inform what's happening with newborn CMV screening. And here are some places you could start if you want to know more about these other things that I didn't talk about as much. I'd encourage you to visit these references as a starting point, or email. You could email me and I can point them to you as well.
Perfect. Thank you, Dr. Cannon. I'm going to put up a poll question here, and that is based on today's information. How would you rate, or how important is it to provide women about information about CMV? So if you would just take a minute and answer that poll, and then we will turn it over to the Q&A period. The question and answer box is now on the left side of your screen, and I will field the questions to Dr. Cannon. I also just want to take a minute and remind you that this webinar is being recorded, and the recording will be posted on infanthearing.org and cmv.usu.edu. Okay. Great. Thank you for answering the poll. I'm going to broadcast the results to the poll now. And then we'll go ahead and talk for just briefly about the upcoming CMV Public Health and Policy Conference. The conference will be held in Salt Lake City, Utah, September 26th and 27th. And it's really a one-of-a-kind conference that's bringing together CMV experts from around the world to discuss public policy, or to public health and policy issues relating to preventing, identifying, and treatment of CMV. The conference has 4 tracks: research to practice, public health implications, early intervention, and family support. And we really have sessions set up for anyone interested in CMV. And for those of you that require continuing education units, we will be offering CMEs, AAA, ASHA, and NCHEC CEUs. And for more information, as indicated on the slide there, please go to cmv.usu.edu. And if you have questions about the conference, certainly feel free to email me. My email address is in the text box on the left side of the screen. So let's go ahead and answer some of the questions that the participants have posted in the Q&A field. Dr. Cannon, the first question is, please define PCR as it relates to CMV screening.
Okay, so PCR is, well, what it stands for is polymerase chain reaction. But what you need to know about it, it was this brilliant technique developed a few decades ago that allows you to detect very small amounts of DNA, and it just amplifies them so you can detect very small amounts. And the reason it's important for newborn screening is because it's the most likely method that would be used to see whether the child's urine or saliva or blood has CMV in it. And it's also commonly, it's becoming more commonly available even within hospitals. But laboratories do lots of PCR testing as well.
Okay, great. And the next question is, how soon does the newborn develop antibodies to CMV from perinatal infection?
So in general, I believe antibody development happens within 7 to 21 days. I'm not really an expert immunologist, but that's about how long it typically takes.
Okay, great. And then would you routinely recommend screening infants who are small for gestational age for CMV?
So, I mean, there's not really data on whether that would be beneficial or not, but it's probably a matter for that would be worth researching for targeted screening, because children who are small for gestational age may be more likely to have CMV infection, and they may be more likely to be at risk of poor outcomes.
Okay, great. And if you have an older child, 8 years old-ish, who is experiencing a decrease in their hearing, should you assume they may also be shedding the virus at that time?
So we don't really have data on, if you're assuming that if you know that they had congenital CMV and that their hearing loss is related to CMV, it's very possible that they are shedding, but there's not very much data on older children. So among younger children, there's more data, but the problem is that older children can be shedding even if they don't have congenital CMV. So it gets harder to tell whether it's an issue of a congenital infection or a infection that they acquired as they got older.
Okay, great. And just as a reminder, if you do have a question, please type your question in the Q&A field that's in the text box on the left-hand side of your screen. Dr. Cannon, our next question is, do you see rates of shedding increase as people with CMV age?
So I guess it depends on, so people who, mostly adults, don't shed as much as kids. So the broad brush is young kids shed a lot, older kids shed less, adults shed less. It's a very hot topic of research whether elderly people shed more than younger people, but I don't think the data are very good in that area.
Okay, great. And then the next question is, do you have any ideas as to why salivary glands are such an intense site of viral load for CMV?
I do not, but somebody might. I'm the wrong person to ask.
Okay, so the next is, can a person who has already had CMV at some point in their life then be infected again by another strand of CMV, therefore making a pregnant woman at risk if she is around CMV, even if she's had a strand in the past?
The answer is yes, absolutely. So a pregnant woman who is CMV seropositive, so she's been infected at some point in the past, can acquire a new strain of CMV and can transmit that new strain to her fetus. So that's why our messages, our behavioral intervention messages, really try to emphasize, regardless of your CMV status, to practice those behaviors to protect yourself from CMV.
Okay, great. The next question is, I have a 5-year-old with congenital cytomegalovirus. What are the risks for me to get reinfected if pregnant again?
I don't think we know any, we don't really have data. There's a couple case studies on mothers who have children with congenital CMV having another child with congenital CMV. But what is likely to be the case is that the risk is about the same as it is for any mother who has had CMV previously. So most often mothers are exposed to children. There's not really evidence that being exposed to a child, an older child, let's say a 5-year-old with congenital CMV is more likely to be shedding than another child who didn't have congenital CMV. So in other words, the exposure risk is probably the same. Just if you have a 5-year-old child, you have some risk. It's probably not as high as if you had a 1-year-old or 2-year-old because they're going to have a lower viral load most likely, and they're less likely to get their saliva or urine on you compared to a 1-year-old.
Okay, great. And then, again, these are questions that people are typing in. So if this is not the mother's initial infection with CMV, then you are still thinking that there is no risk to her subsequent pregnancies?
There is some risk. So basically, if you've been infected before, you probably are less likely to have a child who has the poor outcomes. So you're still at risk of getting reinfected and infecting your fetus, but if that happens, it's likely that the risk is lower that your infected child will have disability or more severe disability.
Okay. And has newborn screening for CMV been presented to the Secretary's Advisory Committee for Inheritable Disorders in Newborn and Children as a candidate condition?
So, well, let me see if I can, I'll tell you what I know. My understanding was when they first developed, when that committee first developed the sort of criteria and how they scored the different conditions, that they looked at a bunch of different things and that CMV was one of them, and that it didn't reach the cutoff that they determined at that time. But I don't know that it was specifically presented the way, new conditions are presented now. I think it was just done as part of a big group of conditions that were looked at when they initially made that framework for deciding what to recommend. I have heard of some interest in bringing it up now that there's more data than there were 10 or 15 years ago, but that's about the extent of my knowledge.
Okay, great. And I just want to draw your attention to the final poll of the conference. Are you planning on attending the CMV Public Health and Policy Conference? If you'll just take a minute to answer that, and we'll take a few more questions, and then Dr. Cannon has graciously given his email address, and so if we do not get to all of the questions, he's willing to answer them for you, or better yet, we would love to see you at the Public Health and Policy Conference, and there will be lots of opportunities to learn more information about CMV as well as interact with all of the presenters of the conference. So we'll take 2 more questions and then sign off for the afternoon. So Dr. Cannon, what does the antiviral do for children with CMV? Does it stop the shedding?
So the evidence from the clinical trial is that it does reduce shedding and sometimes eliminate it, but if I recall correctly, it can. Some of the children who were treated, so they were treated for 6 weeks, that some of them or many of them returned to shedding later on.
Okay. And then our last question that we'll take today is, if a child has hearing loss at birth, do all states require screening for CMV?
So right now, I think 49 states do not require it. I believe it's just Utah where that's a state law, but maybe someone else on this call will have more information on that. But no, it's not currently, to my knowledge, being done as part of a state program in any other state, although there are a few places where it's being done as a research sort of item, and or where academic institutions are collaborating with state health departments to do targeted screening.
Okay, great. Thank you for taking the time to answer those questions. And so we will wrap up for today. Again, Dr. Cannon is willing to answer your questions, and his email is indicated on the slide right now. I did just want to remind you that the recording of the presentation will be available on infanthearing.org, as well as cmv.usu.edu, as well as the PDF version of the slide deck that Dr. Cannon presented today. Again, we'd love to see you at the CMV Public Health and Policy Conference at the end of September. And for more information about the conference, please go to cmv.usu.edu, or feel free to email me at my email address that's indicated on the left side of the screen. So we will sign off for now, and we appreciate Dr. Cannon taking time out of his busy schedule to share his invaluable knowledge about CMV with all of us. And we appreciate